Good evening, everyone. Today is the fourth day of the webinar series talking about the health awareness of transgender and sexual minorities. Today's topic is very important, and it is the sex reassignment or reaffirmation surgery for a transgender person so that they can transition to their self identified gender. Because it is very important for a person to project themselves physically also the way they feel inside to the outer society. It gives them a sort of self confidence, even. So, for a transgender person to actually take the decision to undergo this sort of surgery, they have to go through a multitude of steps, which is not so easy because there is a lot of stigma associated with the transgender community, and also the fact that they are ready to take on the journey of surgery itself is actually a daunting task for them, both psychologically and also health wise. So both pre and post surgery, they have to take care of themselves in a multitude of ways so that the journey becomes very easy or calm for them, so that they can actually be happy when they become their true self finally. As doctors, basically we know about facial reconstruction surgeries and chest and genitalia reconstruction. So today we have amongst us an eminent speaker who is Dr. Sandeep Vijay Raghavan, Professor of Plastic Surgery at Amrita Hospitals, Kochi, who's with us to take us deep into the finer and intricate details of sex reassignment surgery. So we welcome you, sir, to this program. And
Thank you very much.
we are actually waiting eagerly to hear what the expert has to speak about this topic. So with these few words, let me conclude my welcome address. And now I hand over the mic to Dr. Avni Madam to do the introductions of the speaker. Thank you.
Thank you so much, Anju. Good evening, everybody. So like Anju said, we are having a very unique series going on, and today's the fourth session. So to just wrap up just what she said, I always feel that it's basically a person who is trapped in a body, and today's session is going to be about a journey where they can be freed and free as they want to be. So for this, we have an expert speaker with us, Dr. Sandeep Vijay Raghavan. He is a professor of plastic surgery since 2011 at Amrita Hospitals, Kochi. He studied at Calicut Medical College, did his MS in general surgery from Coimbatore Medical College, and MCH in plastic surgery from Kottayam Medical College. He has been actively doing these surgeries for the trans people since 2017 and has performed more than 300 cases so far. So this was what his profile said. And at a personal level, I know him, and I know sir personally to be a very sweet, jovial, and a very empathetic person who is definitely very famous far and wide for his surgical skills and abilities. But more than that, he's appreciated for the love for his patients and the kind of interaction that he develops with the patients and their bystanders, which oftentimes for such surgeries, especially like what Anju mentioned, it is such a traumatizing procedure in itself. But his capability to interact with the patients and bystanders also helps allay this apprehensions that they have. So we are very eagerly waiting for the talk. So over to you, Sandeep sir.
Thank you very much, Avani and Anju, for that very kind introduction. I'll just share the screen. Is the screen visible?
Yes, sir.
Yes, sir.
Yes. Yeah. So at the outset, let me thank the association, both the Radiology Society as well as the Indian Medical Association, for actually selecting such a wonderful topic for your series of discussions. And also, I would like to thank you to invite me to talk on a topic which is very close to my heart. So GAS, or gender affirmation surgery, that is how it is called. Previously it used to be called a sex reassignment surgery, but it is one and the same. And we are trying to be more correct in the usage of the terminologies, where people are not offended. So that is the basic idea, because the gender is something which is the correct thing. That is in the mind, and that is the correct thing, not the sex. So some surgeries performed to make sure that the gender is correctly shown outside is this gender affirmation surgery. So yeah, so when we actually start off talking of gender affirmation surgery, a bit of the history also we will go. Basically, what I will do today is try to make it, I'm sure that all of you would have heard of many gender affirmation surgeries, but what I will try to do is try to talk of something which is less known to people. And then, of course, we can actually discuss about all your questions about the things that you know. In whatever way I'm able to explain it to you, I'll try to explain it to you. Okay, so I've actually tried to keep it short, and let us see how things go. So this particular topic, we would feel that it is a very new topic, and there is a reason for that. But at the same time, actually, if you see in 1700s also, these kind of topics were discussed, but in more discreet, in a closed circuit. And actually, the first recorded medical literature was in 1877 by Kraft Ebbings. He actually described about cross-gender behavior of some people. Then in 1910, Magnus Hirschfeld's, he had actually written a more elaborate publication called Die Transvestism in, I think, German language. But the most famous person was Harry Benjamin, because he was kind of the bedrock of the current WPATH. In fact, the Harry Benjamin Foundation only transformed into World Professional Association for Transgender Health. That's WPATH, which is actually looking after setting standards for care for the trans people. So he, unfortunately, though he was a German geriatrist, though he was actually mainly in US. Yeah. So many things that were there in his mind, he was not able to actually bring it out into this one. So he used to refer his patients also. So he was basically based in New York, and he got interested in seeing the work of Stinak, who was experimenting initially in changing the sex of animals. So he got wondering whether it is possible to do the same thing for human beings. And then actually the geriatric patients whom he was actually treating, he started using endocrine therapies for them. So then his most important thing was when a person who was actually named Van, he was actually 23 years and he wanted first time a sex reassignment. Unfortunately, it was not permitted in US at that particular point of time. And then he found out, and then he actually referred the patient to Germany for undergoing the surgical procedures there. And that is how his interest in transgender surgeries actually evolved. The first big surgery that was actually a most publicized surgery was in 1952 by a person named Christian Johnson. He underwent a sex reassignment surgery in Denmark. But what he did was that he publicized it to a great extent in US, and that is how this particular terminologies and the people came into the limelight at that particular point of time. But you would actually see that many of us, after we were born, I was born in 1970, but there were articles in JAMA, that is a Journal of American Medical Association, in 1978, which describes the transgenders as like when the transgender thing was coming up, they used to say that most gender clinics report that many applicants for surgery are actually psychopaths. See, psychopaths seeking notoriety, masochistic homosexuals, and borderline psychotics. So this was how a reputed medical journal used to describe transgenders, say 44 years back. I'm sure that the previous speakers over the last couple of days would have actually told you about the history of transgenders, how it was a very accepted group of people since time immemorial, to as late as the 17th century, when the Britishers actually came to India and made it into a criminal offense. Okay. And in the world, actually, initial treatments included shock therapy and other aversion therapies to try somehow actually get them out of this particular modality. Of this, one famous person is John Money, who was considered to be a specialist in sex, matters of sex, sex medicine, of course. And he had actually done a lot of research and studies, and he had certain ideas where he used to say that nurture is more important than nature. That is, how you bring up a child is more important than what sex the child is given at birth. So nurture is more important in nature, especially if the child is less than 2 years. Netherlands was a very important place for sex reassignment surgery for a long time. In 1995, actually, there was a study in Netherlands that is a very epoch study. It's a very important study. They compared the autopsied brains of transsexuals along with the brains of the heterosexuals. It is then for the first time that they identified that the brain of a trans woman was very similar to the brain of a female. So they found that the hypothalamus had actually the size of the hypothalamus, the central sulci of the hypothalamus was much larger in females and very similar to the transsexual trans women. Again, there were actually so many people who said that that may not be the correct way to assert it. So then more studies were done, and then they started actually trying to see the physiology behind it. And they actually studied the number of the somatostatin neurons in the same particular area. And again, it showed that trans women were very similar to females. And actually, there's another study that showed that the trans men displayed this pattern consistent with male also. So both ways, they found that organically also there are things in the brain which actually is very specific for female, and it is the same thing which is very specific for a trans woman as well. So they concluded that gender identity evolves as a result of the interactions of the developing brain with the sex hormones. In 2008, another nucleus of the brain, besides the central sulci, another nucleus of the brain, the interstitial nucleus and the anterior hypothalamus, number 3. Again, that was also identified, and that they found is actually very important in gender identification. These findings implicated that hormones, genes, cephalic structures in neurodevelopment theory of gender identity formation is very true, and it is actually very important. In the early surgeries, actually, there was in 1992, there was a Earl Lind. He underwent the first time for gender dysphoria. He underwent bilateral orchidectomy. That is the first published information about gender. I mean, you can't tell a gender reassignment, but at least something to actually get the gender dysphoria down. In 1917, Dr. Alan Hart, he underwent a hysterectomy in order to eliminate menstruation. This was thought to be the first time a psychiatric recommendation was there to actually get a normal, healthy organ out of your body for gender dysphoria. So this is probably a very important year for the psychiatrists, where they have actually, for the first time, agreed that this particular person had a gender dysphoria and has to have a surgery to get rid of his gender dysphoria. The first phalloplasty was actually done by Nikolai Bogoraz. He was a Russian. He had actually done the procedure in 1936. He had actually used the flaps from the anterior abdominal wall. But that was done for a person who had lost his phallus because it was chopped off by his wife. So he did it for a cis person. But the first trans person who underwent phallus reconstruction, phalloplasty, it was done by actually the so-called father of plastic surgery, father of modern plastic surgery, Sir Harold Gillis. So he did a tube-in-tube technique for reconstructing the phallus. The inner portion of the urethra was formed by the groin flap, and the phallus per se was formed by the tubed abdominal flap. There is a very famous discussion on two children, David and Brian Reamer. See, actually, they were identical twins. They were the best example that is possible. They were identical twins. And unfortunately, what happened was that David, when he underwent, he had, I think, he underwent circumcision. And when he underwent the circumcision, he had some accident and his penis was almost totally destroyed. So they were in Canada at that time, and then they were referred to US to Dr. John Money, who was kind of the most famous sex physician. So he was referred there, and then John Money suggested that the best way to actually go about it is to go for a bilateral orchidectomy, and then this was done. And they said that you do one thing, you make your child a girl, and nurture is more important than nature. The child is only a few months old. So at the age of 22 months, the orchidectomy was done for this particular child, and a vulvoplasty also was done. But what happened is that they found that the child was more interested in playing with swords and things like that. And the child wanted to be always with boys and didn't like to go with girls and all, and always was a problematic child in that sense. And what happened is that by 14 years, frustration crept in with the developing breast. And at that time, the local physician over there told the parents that, see, if you want to control this particular child, then you will have to tell the child what really happened. So that was told, and she, or rather he, at that time was very upset and wanted all the things to be reversed. And then the child was put on testosterone and underwent the phalloplasty also. And at 23 years, he married a woman who had 3 children also, and they lived happily for quite a while. But in 2004, what happened is that his wife decided to leave him for some reason, and he was so upset, and within next 48 hours he committed suicide. So that is the history of David Reamer, which was very important because it is this particular incident which truly was a defining study actually, because it was done on identical twins. So we'll talk about surgery now. So we will actually, we'll actually divide this into 2 parts. One would be the surgeries for trans women, and the other would be the surgeries for the trans men. We'll start off with trans women because trans women are more common in India as it is in the world over. And normally in trans women, the surgeries that are done are actually top surgery, bottom surgery, facial feminization. So top surgery is a simple colloquial term for indicating breast augmentation. And bottom surgery, we say for actually the genital surgery. And we have facial feminization, where the face is also dealt with along with the thyroid cartilage. Along with that, many a times surgery is done for actually giving a good shape to the body. So you want what do you call for that? Nice thin waist and a broad hips. All those things can be done with fat injection and liposuction. So contouring procedures are also the additional ancillary procedures that are done. Again, the voice surgeries also are done, but for some reason, it is not a very popular thing currently because many of them are quite happy with the voice. It is very difficult to actually distinguish the voice. So we will start off with the top surgery for trans women. So before we start that, I had actually told you that Harry Benjamin had started a society and that transformed into WPATH, which is a World Professional Association for Transgender Health. So they are having actually standards of care, which is followed all over the world. So the current SOC, that is the standard of care, is the 7th SOC. Actually, 2 years back, the IPAT, the Indian Professional Association for Transgender Health, we have actually got out the Indian SOC, the Indian Standard of Care, which is almost similar to SOC 7. And we hope to actually, because some certain things are very specific to India, so that is actually looked after by the Indian SOC. So they actually came out with certain things that have to be the basic criteria before we actually go for a top surgery for a trans woman. So one is there are many common things for all the surgeries. Certain things are important for bottom surgeries. So the top surgery is not considered not to be that important here, because the thing is that in case the person says that she wants to come back to the male gender, if it is an implant, we can actually remove the implant, or we can actually do liposuctions and other things to actually remove the enlarged breast. So it is a correctable thing. So much importance is not given as we compare it with the genital surgery. So here the most important thing is the persistent gender dysphoria, and we should have a letter of recommendation, that is after assessing the person for at least 6 months by a psychiatrist or a psychologist. And again, important thing is that person should be a major in whichever country he is. So in India, the age of majority is 18 years. So the child should be more than 18 years. The person should be more than 18 years before we do a top surgery. And they should be psychologically and emotionally fit to give a consent, a full informed consent. And many times we say that hormones should be taken, but it is not a very essential criteria. So when we do the pre-op assessment, we see that take the complete history of the patient and do a physical examination. We look for history of diabetes, heart and lung disease, immunosuppressants, etc. History of prior chest surgery for obvious reasons. History of any chest radiation, which is a big taboo for doing a implant. We can actually probably put fat in that condition. Check for bleeding diathesis. And if the person is a smoker, we advise to stop smoking for 4 weeks at least before and after surgery. And if the patient is on hormones, the hormones have to be stopped at least for 2 weeks before the surgery. So the thing is that I had actually told you one thing, that many of these patients, we advise them to actually go for hormone therapy, at least for a year. There's a reason behind that. One, when you take the hormones, you get a feeling of how it is to be a woman. And number two is that very important thing is that the person starts to develop a certain breast. It would be like a Tana 2, that is almost like an adolescent girl's breast. Around 25% of the people, they are quite happy with the size of the breast they have. So they would not want to get any more augmentation done. Again, another 25% of the people, or maybe at least 10% of the people, would be happy if there is small amount of increase in size of the breast. So in those cases, many times fat injection would suffice. Only thing is that adequate amount of fat should be available in the body. Rest of the people may go for the implant augmentation for the breast. So it is definitely, many studies have been done and definitely proven that the breast augmentation improves the breast, the overall satisfaction of the patient, and they have got a feeling of well-being, and definitely it is not a surgery for vanity like we do it in cis women, but it is definitely a surgery to get rid of a part of the gender dysphoria. See, again, gender dysphoria, I just want to just highlight something, what a patient had told me. The patient told me, sir, you are a male. Just imagine tonight you're going to sleep, you're perfectly fine. Tomorrow morning when you get up and you go and look in the mirror when you're brushing your teeth, suddenly you find that your mustache is gone, your beard is gone. And then when you just remove your shirt, you find that there is a big breast over there. And then when you look down, there is the genitals over there. How would you feel? Would you like to go outside? Would you like to meet your patients in this particular manner? Are you ready to wear a dress appropriate to the sex? This is what we actually go through every day. So this is kind of dysphoria that is there. This is actually the words from a trans woman who had actually come to my clinic in the initial phases. So this really touched my heart, and that is probably one reason why we should actually look at them more sympathy. It's not sympathy. We have to actually understand their problems and try to do the best for them. So there is actually some differences that are there between a male and a female chest. So that is very important, and we have to actually inform them about that. One, first and foremost, the male chest is a wider chest. So now you're actually trying to put in a breast in a wider chest. So that shape difference is there, and the nipple areolar complex are much smaller in males, and actually the nipple areolar complex are actually more laterally placed. So this is a very important thing. See, because when you're actually making a breast, we cannot make the breast in the middle and the nipple areolar complex in the side. It is not aesthetically pleasing. Always the nipple areolar complex should be in the middle of the breast mount. So in that case, unless you have a much wider and larger footprint for the breast, it is going to be as though there is one breast over here, one breast here, and a big space in between, which doesn't look very aesthetically pleasing. So many a times we have to actually put a thinner but a wider breast implant, and we have to probably do fat injection also after that. Again, in the male, the sternum is much wider. So that is again one thing, we can't actually put an implant on top of the sternum. It is not good to do that. So that is again one problem that we face. And the shape of the areola is also quite different. In males, you actually find the ovoid areola, and the female, it would be a circular areola. But many people, we find that after we actually do augmentation, it becomes more circular. So this is one important thing, and the most important thing is that we have to tell them that it is very difficult to get a good cleavage. So they have to understand that, and then they should be ready for multiple procedures for getting a good cleavage. So again, they have to come with the letter from the clinical psychiatrist. I'm again emphasizing the same thing, and in the all aspects of the procedure should be actually explained to the patient. We have to tell about the preoperative procedures, perioperative things that have to be done in the postoperative course. Okay. In the postoperative course, we always tell them that they have to wear a sports bra for at least 4 to 6 weeks, and they should avoid strenuous activity again for 4 to 6 weeks. Breast massage should be done at least for 6 months to prevent capsular contracture, and scar massage also should be done. There are potential complications for top surgeries. They are postoperative pain. So to actually prevent postoperative pain, what we do is we do intercostal blocks all along the intercostal nerves over there. And that has actually significantly decreased the postoperative pain, because the initial pain is not that they are pretty comfortable. And sometimes there could be a loss of the nipple sensation. Hypersensitivity is extremely rare, but it is a possibility. Hematoma is probably one problem, hematoma and seroma. It is then that we actually get our radiology colleagues' help, and we try to actually quantify the amount of blood that is there. If it is less than 25 cc, we just leave it there and we explain to the patient. And most of the time we keep checking out. Most of the time that completely gets absorbed. But if it is more than that, the ideal thing would be to take the patient back to the theater, remove the implant, give a good wash, look for any bleeding spots if it is there, remove the clots, and then put back the same implant, or ideally put back a new implant. Infection is another problem that is a possibility. It can come around 1% can have infections. Asymmetry, breast malposition, especially what happens is that many people get into sexual activities and very early on, and it is that time when these implants can actually get malpositioned. Capsular contracture is one problem. So that is it is actually more commonly seen in the older implants. See, currently the most latest implant is a 6th generation implant. So that would be having a ground glass appearance kind of implant. It's very good implant. So in that particular implant, hardly any capsular contracture is reported. But before that, it used to be there. And so for that only, we ask them to go for massage on both the sides for at least 6 months. Then an extremely rare problem is the ALCL, that is a breast implant associated anaplastic large cell lymphoma. It is like a 1 in a million kind of a thing. Again, it is seen with the older implants. The newer implants so far have not shown any case of ALCL. But we have to actually tell the patients that this can happen. The other method of actually getting breast augmentation done is to go in for fat injection. Like I had said before, if you have adequate amount of fat and only a small amount of fat need to be injected, up to 200, 250 cc of fat can be injected. Sometimes you will have to do it multiple times, at least 2 to 3 times we'll have to do, because each time you inject, around 30% of the fat gets is lost. So this is again another option. Then that is about the top surgeries. Then the body contouring, will come to it. The body contouring, if you can actually see this particular this one, the male, the body structure is very different from the female. You can actually see the nice thin waist and the broad hips. So what we can actually do is that we can actually go for liposuctions and fat injections. Many times we actually go and many times we actually go for liposuction in this waist area and then actually do fat injection to this hip area, and that they're pretty happy with it. Again, the hips, buttocks also, many times people want to shade the buttocks, so either with implants or with fat. And estrogen, increase of estrogen, when the people take the estrogen pills, it is found that actually some shape actually develops in the gluteofemoral region. Some shapes also comes without any surgical procedure. Now in the posterior portion, you can actually see that it is important that you see that, yeah, in this particular region, actually it has to be thinned out so that a good buttock elevation is seen. And it is actually more curvaceous kind of a shape for females in this area, compared to males where they actually have actually a concavity over here. It is actually very convex. So once you know, okay, these are the changes, differences in a man and a woman, and the person has got adequate amount of fat either in the belly or in the back or wherever, we can actually do to actually get the shape into the desired and aesthetically pleasing way. Fertility preservation. This is actually very important. Though it is not something that is directly a surgery, it is a very important thing. See, why I want to emphasize on fertility preservation is because one, it is ethical to do that. Number two is that most of you would have heard about top surgery, bottom surgery, all those things, because it has been in the media for quite a while. But fertility preservation is something that is important, that has to be done. We should actually start doing it. And so we'll actually talk of certain things in this particular field. So what is happening is that the fertility preservation is highly underutilized by trans people. So that has to change. The reason why they are not using it probably is because they don't want to delay the surgery. Second is the cost, very important. The cost is very high, and so for that, the money that they have, they don't want to spend it on fertility preservation. Rather, they would want to go for removing the gender dysphoria. and lack of understanding of long-term consequences. So because at that particular time when they're not that mature, they wouldn't have thought about the long-term things. So here, what we can do for the options that are there available with us is that trans men, we can actually store the gamete, or there is an egg or the ovary by cryopreservation. And another very important thing which is low cost is actually gonadal conservation, that is retaining one ovary. This we will come into detail later on. In trans women, we can actually cryopreserve the testis, and also sperm banking also can be done. But these are done in fertility centers, and they have a yearly charge for that. That is pretty expensive. So now the question is, can a trans person be a parent? So this is a very important question that we have to find an answer to. But then fortunately in Europe, these studies have been done. They have actually checked out people, the trans people, either one or both trans people who have got children, biological children. And they found that definitely it is associated with a very positive increase in the quality of the life for these people. So it is very important that they can understand that they can have children. And that second important question was whether a child born to or child reared by a trans couple, how is a child going to be? Is a child going to be normal? Is a child going to become another transgender person? So what is going to happen? So again, studies were done and people have actually documented and found that there is absolutely no problem for these children. They would be cis children if it is so, and they would be actually understanding how their parents are, and it wouldn't be a problem. It is only a problem for certain sections of the cis population, but these children perform extremely well, and they are like any regular children. They don't have any gender identity or crisis or confusion about sexual orientation, etc. And now the question of trans men becoming pregnant. Is it possible? What happens with that? So actually a study has been done on 41 trans men who became pregnant and had given birth. And it was found that majority of them had actually testosterone taken prior to their pregnancy, and then they stopped it when they decided to get pregnant. They used their own eggs actually to achieve the pregnancy and had a natural outcomes over there. And they had normal regular children in probably cesarean, or they would have had a normal delivery. So again, the only problem with that was that there was severe gender dysphoria. So when they were becoming pregnant, they were very upset about it. But other than that, the children and other things, and it is a possibility that trans people, trans men can actually conceive, even though they have taken testosterone for a long time, they can conceive and have a normal, healthy baby. Now again, we used to actually see that the trans men were advised to actually remove their ovaries prior to taking testosterone. The thought process was that it is because of, it can actually, because when you have two hormones at very high concentration, which are opposing each other, there is a possibility of cancer. And that here there's a higher incidence of ovarian cancer. So it has actually been found that it is not true. There is no increase in amount of ovarian cancer for these kind of people who are having their ovaries as well as taking testosterone. And actually studies have shown that most of the ovarian cancers actually originate in the salpinges, and probably salpingectomy is a more important thing than oophorectomy. So this is called opportunistic salpingectomy. So here what has happened, what is done is that the fallopian tubes, bilateral fallopian tubes are removed along with the hysterectomy. And usually one ovary also can be removed at the same time. So what happens is that then the risk of developing any ovarian cancer, even the regular risk of developing ovarian cancer is also not there. So this is a risk reducing salpingectomy. So, but there is some exceptions for these recommendations. That is when there is a strong family history and whether there is BRCA1, BRCA2 germline mutation is there, then we advise that they have to go in for a bilateral oophorectomy as well. So it has been found that prolonged testosterone use, the ovarian tissue, whether it will get damaged and things like that, it has been found that nothing happens, and the cortical follicles are well preserved, and then you can use this and have your own children also. So again, the second important thing is that oophorectomy leads to osteoporosis, especially after stopping testosterone. Why? Because testosterone basically increases the bone density and increases the bone size. So when you actually do bilateral oophorectomy plus stop the testosterone, then you are likely to have osteoporosis. So again, certain other things is that it is not advisable to remove the vagina. That is, doing a vaginectomy is not advised when part of the cervix is still there. The main reason is that you are unable to do a cancer testing for that. The pap smear, we are not able to take the pap smear and check for CS cervix. So that is why we say that vaginectomy should not be done when the cervix is intact. You have to remove the cervix as well. And also the other important thing is that when you are doing vaginectomy, a very important thing, see, vaginal tissue is very good tissue, very thick mucosal tissue. There is no hair, nothing over there, and well vascularized tissue. So this should be used for urethral lengthening, because for trans men, the very difficult thing about trans men is that we know that the length of a female urethra is only 4 centimeters, whereas the length of a male urethra is 16 centimeters. So we want to actually increase the length of the female urethra by at least another 4 centimeters, so that you have a length of around 8 centimeters. So it is easy to do phalloplasty. So the best tissue to do this length increase is the vaginal tissue. So ideally, when you're doing a vaginectomy, use that tissue to increase the size of the urethra, because the adjoining tissue, we can actually easily remove it and then tube it and use it for increasing the length of the urethra. So many a times the distal vaginectomy is usually delayed for this purpose. Again, when we're doing hysterectomy, we can actually combine it along with the chest surgeries also, because as far as possible, you combine multiple surgeries and decrease the number of total procedures. And here we have to actually, when we are doing this, we have to actually discuss in detail about fertility preservation options. And it is very important that in the informed consent, you write about the patient has told that the patient does not want, wants to get a oophorectomy done and does not want to preserve the ovary or preserve the follicles, etc. Now we'll come to the bottom surgery for trans women. So again, the criteria for here is more or less similar to the males, but again, here at least 12 months of observation should be done by the psychiatrist or psychologist. And second thing is that at least two people, at least one psychiatrist and one psychologist, or two psychiatrists at least, should have given, should have examined the person and given the letter recommending that the procedure can be done for the patient. So at least it's good that they are, they wait for at least 12 months before they actually give the recommendation. And in this 12 months, ideally, they should actually take hormone therapy, hormone replacement therapy, so that they have an understanding of how it is going to be. And they may or may not do cross-dressing also. So the bottom surgery is actually quite sophisticated, and many a times they are aesthetically indistinguishable from cis vagina. And they are able to have sexual intercourse And again, the urination they can actually do in the sitting position. They will not be able to do the standing position. And they have erogenous sensation, and most of them, they say that they are getting orgasm as well. So, and a history portion, the world's first sex reassignment surgery was actually done for someone called Lily, and actually in Germany. And I think Lily was a Dutch lady for whom, in fact, a movie was also there on Lily. But unfortunately, due to the complications of the procedure, the patient died because you just that it happened in 1933. Some Clostridium infection, something came, and unfortunately, patient had died. But even before this 1933 surgery, castrations were done and recorded nearly 1,000 years back in many of the biblical texts as well. So we must understand that there are many different methods of actually doing a bottom surgery, but certain things are common for all these things, all these different types of surgeries. So one is that the corpus cavernosa, which is the erectile tissue of the female, of the male penis, that has to be totally discarded. It is very important to do that. Many times, some portion is retained and what is outside only is removed. What happens is that when the person tries to undergo a sexual act, let us imagine that the vagina has been reconstructed and the person is trying to have a sexual act, then what happens is that this corpus cavernosa becomes erect and it becomes larger and it becomes painful, as well as there will be difficulty in actually doing an intercourse. So that is why it is very important that the corpus cavernosa is totally removed right up to the pubic bone, and so that these things, problems do not happen. The most important portion probably is to actually get a sensate glans, because glans is the thing that is going to be made into the clitoris, and all the erogenous sensation, orgasms, everything depends on the sensation that the glans is going to have. So it is very important that the dorsal artery and veins, as well as the nerve supply to the glans, is preserved. The third thing that is common is actually the shortening of the urethra. We all know that the urethra actually opens to the end of the penis and the urine actually flows forward. But now the female urethra actually is facing downward, so that when the person squats, it should not actually go and splash onto the thighs. It should actually go down into the commode. So this is very important. So what happens is that the urethral opening is made in the bulbospongiosus, and so that it faces downwards and urination with force goes downwards into the loop. And next important thing is to make the labia majora and the minora. So the penile base tissue and the scrotal tissue is actually used to make the labia majora and minora. So so the things the scientific terminology would be clitoroplasty. We would be doing urethral shortening. We would be doing orchidectomy, vaginoplasty, and labioplasty. So there are different techniques for doing vaginoplasty. So we have penile inversion vaginoplasty. Then we can actually use gut. We can actually use either the sigmoid colon or the ileal loop. Then we could use the skin grafts. Usually the skin grafts taken from the scrotum or skin from the thigh can be used for vaginoplasty. So these are the functional vaginoplasties. Some people, either for monetary reasons or otherwise, they would tell that they just want to have a shape surgery where we do not reconstruct the vagina. Right. So the most common technique that is used is a penile inversion vaginoplasty. So the important thing is we should know where actually the vagina is made. So you can actually see this is the vagina. You can actually see that the prostate is over there, and this is the rectum. This is a small space in between the prostate and vagina and the rectum. Actually, there is no space over there. there's a Denonvelius fascia is there, and so we have to actually carefully make that space over there. That is where the penile tissue is actually inverted and pushed inside. So many times what happens nowadays is that the older times we used to do, the initial times we used to use only the penile skin for that. And then after it evolved in using actually the penile skin plus the urethra, that is urethral mucosa for some lubrication, but it has its own problems. Like it takes a very long time to actually settle down. There is bleeding, there is hematoma. So many issues are there with that. So slowly that is not being used. And now most of the time what we use is that we combine the penile skin as well as the skin from the scrotum, and that is actually pushed into this. And it is important thing is that we have to actually fix it over there by actually taking a bite through the sacrospinous ligament with a non-absorbable suture and fixing and pulling this up and fixing it over there with this particular suture. So here again, you can actually see very clearly what I had mentioned. You can actually see this is the vagina. This is actually the bulbospongiosus portion, and the penis, which was actually facing forward, the urethra, which was facing forward, actually is now facing downward. You can actually see that is facing downwards instead of going forward. So that angle is changed, and the clitoris is there somewhere in the front of the pubic bone. Normally we would be having the corpus cavernosa also, the base of the corpus cavernosa, and many times we actually fix this new clitoris onto that area, and that is how we actually do this. It is very important to have a proper pre-op assessment. We have to actually see the size of the flaccid penis, and if it is less than 2 inches, we have to actually tell them that the length may be inadequate, and sometimes we might have to use skin also for actually increasing the length of the vagina. Again, we have to check for the penile girth at the base of the penis, and especially when we are only using the penile tissue for reconstructing the vagina. But nowadays, almost all the cases we are using actually the scrotal skin in addition to the penile skin. So this is not that important now. And another thing is to ask for a history of tucking. History of tucking is actually what these trans women, they try to do is actually they try to tuck in the penis between their legs. They always like to feel that the penis is not there. They keep pushing that penis down between their legs and then watch their body and then get the happiness that it looks like a female body and things like that. So it does two things. One, it makes a penis very mobile, and what happens is the base of the penis moves more posteriorly and towards where the actual vagina is. So in those cases, actually it is very good, and we can actually tell them, no, in the intervening time between seeing the patient in the OP and doing the proper surgery, that they have to do the tucking, so that it becomes more easier for us and we can get a much better result. In the preoperative planning, the most important thing is that we have to have a proper bowel preparation once or twice the day before. It is very important because there is a chance that the rectum can get injured. If the rectum gets injured and if you have not done a bowel preparation, you might even have to go in for a colostomy. But if the rectum is well prepared, there is no fecal matter coming out, then we can actually get away with actually doing a closure of the rent in the rectum in 2 layers and giving Riles tube feeds for a week. And most of the time, we would not have a problem of a rectovaginal fistula. Again, preoperative antibiotics is very important because these are prolonged surgeries, and then we have to do DVT prophylaxis. And we have to actually sit to the patient and get the patient's opinion of where the new clitoris should be. Ideally, it should be over the pubic bone. And in case the penis is found to be hairy, then we have to actually go in for laser therapy, at least for 6 to 8 sittings. So the technique that is used for this is called penile disassembly technique. And here you can actually see that the penis is disassembled. You can actually see the skin is here. And here you can actually see the neurovascular bundle over there with the glands over there. And here is the urethra. This is urethra. and here is a corpus cavernosa. This is the corpus cavernosa. So you disassemble the penis, and then you remove this corpus cavernosa, you decrease the size of the urethra, and this is retained. This you actually get it like a small loop in the pubic area, so that your glans is somewhere over here, and the skin is used to actually form the new vagina. So, like I said previously, ligation of the corpus cavernosa is very important, so that all the erectile tissue is completely removed, and new clitoris is fabricated using the glans penis. And also, we actually utilize some amount of the prepusal skin also, so that forms a hood for the glans penis. So the glans penis gets hidden underneath the hood, just like a cis woman. So this is pretty good. The techniques that we are using now is pretty good to actually get a aesthetically pleasing clitoris also. Then the vaginal orifice is made between the rectum and the urethra, and it is important. So this, I said, the anterior and posterior wall, but again, the lateral side walls, it is very important. So we should actually remove all the muscles, or rather we should divide all the muscles almost up to the pelvic bones. So in between, you might get some bleeding points. You might have to ligate those bleeding points, but adequate amount of tissue should be there. Initially, we used to say that at least 4 fingers you should be able to pass 4 fingers. Nowadays, we are able to do 5 fingers and sometimes even larger than that as well. Our goal is to achieve at least 6 inches depth for the new vagina. Then the penile and scrotal flaps are actually stitched together and pushed into this vaginal orifice. The skin of the scrotum is again used to make the labia majora and part of the labia minora. And once this is done, we actually fasten a sponge put over a condom. We actually keep aspirating out all the air so that it becomes tight, and then you keep it into the new vagina and we release it. Either we can use that, or we can, along with that, we can actually do something called a negative pressure wound therapy. Especially if you're having some skin graft that is put inside, you put a negative pressure wound therapy also. So what it does is that it keeps the graft in situ, and it decreases the edema, and it decreases any hematoma that is coming. This whole swelling that can come in the labia majora minora area and all comes down with negative pressure wound therapy. Post-operative care, we keep the Foley's catheter for 4 days, and the sponge is removed probably by the 5th day. And after that, we teach the patient how to actually clean that area with dilute betaine solution. Dilatation is started by around 7 to 10 days. And we give them a set of vaginal dilators, and they are supposed to put in the largest dilator and keep it in situ at least for 15 minutes, 3 times a day. They have to do it for at least 1 year. Complications, around 30% chance of complications are there for bottom surgery in trans women. The commonest thing is dehiscence, and usually if dehiscence is there, most of the times you don't have to do secondary suturing. It will actually settle down and heal very nicely over there. The risk increases with obesity, smoking, excessive activity immediately after this, and deficiency of penile skin. One problem with our trans people are that they have certain customs where they refuse to eat high protein diet. They have their own ways of doing it. They clean that particular area with boiling water. So that could add to actually dehiscence and other risky problems over there. Then bleeding is a common problem in the urethral area. So that is why the corpus spongiosum, the urethral tissue that is actually used to reconstruct the introitus area, we actually take sutures all around it, continuous sutures all around it to actually decrease the bleeding. Then edema is a real problem, and one way to get rid of that is to go for negative pressure wound therapy. Hematoma, like I said, could be a late thing also, and in case it is there, you might have to open a few sutures and let out the hematoma. The other complications are clitoral loss of sensation. There could be stricture formation. In case there are stricture formations, you have to wait at least for 3 months, and then you will have to probably release the tissue with in the 3 o'clock and 9 o'clock position, so that no damage to the rectum or the urethra happens. There could be posterior webbing, loss of the depth of the vagina, and loss of the definition for labia minora. In fact, our trans women, for some reason, they are happy to not have a labia minora. If you reconstruct a labia minora, I have actually seen many people coming back to me and telling, doctor, you have done something wrong. You please get rid of it. I want a nice flat thing over there, like how my friends have got it. So that is also another thing. So the next important way of doing a vaginoplasty is to use an intestine for vaginoplasty. So certain reasons are there where it is a must to do an intestinal vaginoplasty. That is when there is insufficient scrotal and penile skin for some dysagenesis and things like that, you have to use the intestine for doing the vaginoplasty. Some unique properties for the intestinal tissue is that one, it gives a good feeling when they're having sexual intercourse. Number two is that there is some lubrication that is happening over there. The third thing is that the chance of it actually shrinking is much less, and length is never a problem. If you can actually have a very long 8 inches, 9 inches, 12 inches long vagina also, and the texture of this is very similar to the vaginal tissue. And most important is that there is no hair and sebaceous tissue. Because if there is hair and sebaceous tissue, especially when you're using the penile inversion vaginoplasty, you have to clean that area at least once in 3 days. So here, those kind of problems are not there usually. Two types of okay, there are certain contraindications. The contraindications of using vagina is when you can't you give a GA. It's a relative contraindication, history of intestinal malignancies, inflammatory bowel disease, extensive abdominal surgeries, smoking, and obesity. When BMI is more than 30, it is very difficult to do these intestinal surgeries, and we have to either ask them to actually decrease their weight and come, or we'll have to do penile inversion vaginoplasty. So we can actually go in for minimally invasive techniques like laparoscopically and robotic the removal of the sigmoid colon. And again, here that obesity is a factor. You can actually see that we take one of those particular branches and it is supplying almost this much area, and that can be divided over here, and that is closed in one end, and it comes down as a vagina. And you do the anastomosis from here to here, you do the anastomosis over there. So ideally, the colon should not be visible outside, because if it is visible outside, immediately it will form will be angry red looking thing, and it's a bit unnatural. So we have to have some amount of the penile and the scrotal skin, and it should be slightly, at least a centimeter or two below the skin surface. Problems and complications is that intraoperative injury to adjacent structures could be there. Colonic conduit can necrose, neovagina can stenose, neovaginal fistula can happen, neovaginal prolapse can happen, neovaginitis can happen, and if it is actually projecting outside, there is always a small chance of malignancy formation also. And again, the problems, we know that any of these surgeries can actually have intestinal obstruction, and because approximately 10% of laparotomies could have some sort of intestinal obstruction. And in case there is intestinal obstruction, again, most of the time, 90% of the time, you get away by doing 90 or 95% of the time, you get away by doing conservative management, nil oral, Riles tube, etc. But in some cases, you might have to go back to actually release all the adhesions and wait for things to settle down. So that is one thing. The other way of actually doing an intestine is to use the ileal conduit, but ileal conduit has got its own problems because the vascular pedicle is way above, and the length of the gut would be at least 12 inches, because from the upper abdomen to the vaginal orifice, it has to extend, and there is much more discharge than in the sigmoid. So many times we do not do ileal vaginoplasty. Now we'll come to facial feminization surgery. Okay, now in this period, besides for a trans woman, besides the breast, the next most important thing probably would be a facial feminization, because the giveaway before the COVID was the face, because there are distinct features in the face which could not be hid with a mask also. Some could be hid with a mask, but most of them cannot be hidden with a mask. So this is basically done to actually soften the masculine face, no? And to give a more feminine face, because certain structures are there that is actually recognized by even lay people and associated with being a male. So we have to find out what it is. We know what these are, and these are corrected and to soften the look. So the three basic pillars for craniofacial gender reassignment we know is the frontonasal orbital complex. That is this area, this whole area. That is one of the most important things. The nose and the jaw, and of course the cheek is also very important. Trachea is another giveaway because of the Adam's apple. So in this particular picture, you can actually see the differences in the male skeleton. You can actually see this is the front. This is the frontal bone, and you can actually, there's a frontal sinus. This would be very prominent in males, and you can actually see that the orbit also, this bone comes down here a bit, and ideally if it is slightly above and giving a circular feature, it would look much better in a female. Then the jaw is, you can see the flared out angle of the mandible, and here the mandible is more squarer over here. So these should be softened over here. This is actually the biggest giveaway I feel. And the third thing is probably the cheek. See, in a male, the cheekbone is prominent, but in a female, what happens is that the soft tissue is prominent over there. And when we actually decrease all these things, unless you have more prominence, the feminine features would not stand out. So it is very important many a times that we actually put in a small implant, a malar implant, for getting a good cheek for these people. So we do a facial analysis, and to plan out what all we do, sometimes the upper third, we do a hairline correction, and like I said, the forehead correction. In the middle face, we do the cheek, nose, and the upper lip. Lower third, we actually correct the jawline, and the neck, we actually correct the Adam's apple. So there's a nasofrontal orbit. We actually do a incision like this. Nowadays, we actually go right in the forehead only, the hairline, and we actually get that the whole of the frontal flap. We actually get it down. We go and see the frontal sinus. We actually use a saw, cut open this area, and then burr it off to the required dimension. Even this prominence to the nasion area, that is also actually pushed inside, and then fixed it with 2 plates on either sides. And in the same sitting, we actually go here. Here, this portion of the supraorbital rim is also taken off, so that the person gets a nice nice shape for the eyes, so the open eyes appearance would be there. The malar region and jaw, like I said, in the malar region, through the intraoral approach, we actually create a small plane, and then we put the malar implant over there, put 2 screws and fix it over there. In the jaw, we actually remove the flared area, and this bone from that square appearance, we try to actually get it into a nice V kind of appearance. So these are the incisions that are made for these surgeries. So here you go here, and this much area of the bone is actually removed. And in the front portion, we might not remove bone, but we might advance it also to give a more feminine appearance. Here you can see the square appearance. So this lateral area, we actually use a burr to actually burr off this, so that a nice pleasing V kind of appearance is there. If it is difficult over there, we might actually cut open like this, remove a chunk of tissue bone in the center, and bring these 2 edges together and fix it in the center. We can actually even advance it in case you require some advanced vaginoplasty for these people. Now, thyroid cartilage removal is again not a very difficult procedure. Through a small incision, the cervicomental angle, we go down and go to the thyroid cartilage and slowly shave off the top portion of the thyroid cartilage. Other ancillary procedures that are done is actually hairline correction. That's a very important thing, because a female pattern is very different from a male pattern. That would not usually get corrected with just taking hormones. So in those cases, we might actually have to add in some hair transplant for that. And then we do a brow lift also, so that the female eyebrow, in a male, the eyebrow is straight, but in a female, you have the eyebrow actually rising from the lower portion, keeps rising, goes to the first two-thirds, medial two-thirds, it will be rising, and from that highest point, it will be coming down. So that is actually lifted up using a brow lift over there. In the lip, we actually give a small elevation for the lip, a small pouting by taking off a small bit of tissue over there. Then rhinoplasty is also done to actually decrease the size of the nose. Coming to trans men, again, we follow the criteria set up by the WPATH. And initial things they're very concerned is usually the chest. Many of them, they come to our OPD with tight elastocrate bandage put around the chest wall because of the gender dysphoria. No? And many times we find that that area is very difficult to dissect also because of fibrosis, because of years of putting a lot of pressure over there. Important thing is that we have to discuss about combining the chest surgery along with hysterectomy and oophorectomy and salpingectomy. And in the preoperative thing, we have to ask them about smoking, overweight, diabetes. In case they are on hormones, to stop the hormones at least 2 weeks prior to the surgery. The top surgery for trans men, we can actually go for 3 different methods. One is like in this particular thing, we can actually go by a small curvilinear incision over here for small breast and take out the whole breast tissue through those particular thing like you do for a gynecomastia. Or if it's slightly bigger, we can actually go for double incision. And double incision, it's like a donut incision. And then through a small incision here, remove the much bigger gland over there. And what we can do here is we can actually decrease the size of the areola also over here. That is the advantage. And the nipple, also we can cut a portion of the nipple, remove, excise a portion of the nipple, and then get the size of the nipple down, either in the same setting or in a different setting. In people with very large breasts, then you will have to go in for a double incision. Like this is a double incision. We'll have to remove the whole breast tissue, and nipple areolar complex is kept there as a skin graft. The problem is that you have this particular line over here, and in the Indian patients, this line is going to hypertrophy, and hyperpigmentation also can come, and that is going to be there for a lifetime. So that is a problem with this particular thing. Okay, sorry. Yeah. So as far as possible, we should try to avoid that. Coming to female to male gender affirmation phalloplasty, the goal of penile reconstruction is to have a functionally and aesthetically pleasing phallus. Many times we do it in multiple stages. In the first stage, we advise for a vaginectomy. Following a hysterectomy, etc., we go for a vaginectomy and the urethral length. Like I said, the natural female urethra is only 4 centimeters, and it is very difficult to actually reconstruct it. Microsurgery is possible, but it is extremely difficult, and it will be very tight, and there is a chance that fistula formation can come at the anastomotic site. So that is why we advise them to actually go for a urethral lengthening the first stage, and the second stage go for a microsurgical reconstruction of the phallus and do the scrotoplasty over there. And after 3 months or 6 months, we can actually put in silicone implants for the testis. Radial forearm free flap is the preferred free flap because you get aesthetically pleasing phallus with that. And it is the most frequently used one. The good thing is that you can actually get a sensate flap. You can actually get the erogenous sensation as well as a regular sensation. And it would not be too large in size, it would not be too broad in size, and then they can actually have a silicone implant placed later on, and then they can have penetrative sex with the partners. And with this, we can actually, with a tube-in-tube technique, we can actually create the urethra also in the first setting, and then they are able to actually pass urine through the end of the phallus. And you can actually reconstruct the normal-looking glands also for these people. And they get good erogenous sensation. Pre-operative preparation, again, in case it is required, you'll have to do de-ablation of the forearm. If the area where the urethra is going to have some hair, that hair we'll have to actually go for a laser de-ablation, at least for 6 to 8 weeks, 6 to 8 sessions. And they should stop the steroids. They should the testosterone. They should stop at least 2 weeks prior to surgery. And we can't do this without the patient having a hysterectomy and oophorectomy for obvious reasons. Sequence of surgery usually for trans men is to go in for a subcutaneous mastectomy at the first surgery. Either you can do it as a separate one, or you can combine it along with the hysterectomy, oophorectomy, vaginectomy, scrotoplasty, and reconstruction of the increase in the length of the urethra, or you do that as a separate setting. But ideally, it is good to actually do all these things together. The reason is that hysterectomy and oophorectomy you're probably doing by a laparoscope, and underneath the same sitting, you can actually, if you're doing that from the top, you can actually do the vaginectomy more easily, because somebody is actually dissecting from top, and the chances of any complications arising, damage to rectum, etc., is much less if you're doing from the top as well as the bottom. And the same sitting, instead of discarding the entire vagina, you're using the vagina to reconstruct the urethra also. And the third stage, once you're very sure that there is no fistula, etc., and the urethra is outside, almost the tip of the clitoris, then you can actually go in for the phalloplasty, at least 3 months after this. So this is one, if you would have noticed, you would not have seen any of my clinical pictures in this particular presentation. The main reason is because my laptop had an issue and I was not able to take out any of those pictures from the laptop. So one of our trans men, I just asked him whether he has got a picture, and this poor guy, he was actually in a train. He said, I told him that 9 o'clock we have a presentation, and in the train's lavatory, he had actually taken this picture and he had actually sent it to me. And he had actually taken a voiding video also, but unfortunately, I was not able to put it into this iPad. Now, complications, again, trans men, there is around 70% complication rate. There are a variety of complications can come. It would be partial or total flap loss, hematoma, insensate flap, skin graft loss, chronic pain, numbness, urinary complications, hypertrophic scarring. That is very common. The forearm scars could be pretty ugly. Many times they actually go in for tattooing of the forearms. For that, there could be problems related to taking an important vessel, the radial forearm. So those problems all could be there. So this is a nutshell of gender affirmation surgery for you. I hope I have not taken too much of the time, and I'm happy to take questions.
Anju, you're taking it. So thank you so much, Dr. Sandeep. That was amazing, because we understood so many things that we have never understood or comprehended before. In fact, you made such complex surgeries sound very simple the way you explained it. There are a few questions in the chat box, actually. Okay, do the person need to take hormone therapy before SRS?
Yeah, see, now the question is, now the question is bottom surgery. Ideally, you take hormones before you actually going in for the SRS. But as per the current rule, it is not mandatory that the person has to take hormones before the surgery. In trans men, we always recommend to take the testosterone. The main reason for that is because we want to have a clitoromegaly. We want the clitoris to increase in size. Because if the clitoris increase in size, then we can actually increase the urethra till the end of the clitoris. So we would get around 4 to 6 centimeters of the clitoral length also, and the vagina could extend, the urethra could extend up to that. So it would be very good in actually reconstructing the phallus. That is basically for that purpose. But in case someone is actually coming to you who has not done, who has not taken any hormones, we cannot deny them the surgery.
Okay, the next question is, have any patients experienced any urinary problems as a result of vaginectomy?
Yes. See, the thing is, when most of these roles in these new roles, they have got urinary. They could have urinary problems. One, because of the catheterization that we do, because most of these patients would have to be on catheter, especially when we are actually going to do a phalloplasty or a meteoroplasty. We'll have to have the catheter for a week or more than a week. Sometimes we'll have to have, most of the times we'll be having a SPC also, suprapubic cystostomy also. So there is a chance that they can have some sort of urinary tract infection. One. Second thing is that the more problems are seen in the trans women, because what happens is that you have one place, like especially in penile inversion, vaginoplasty, you have the urethra that is suddenly shortened. And if they don't keep their vagina very clean, you could actually have some sort of infection over there, and that could actually spread and cause UTI also. Yes, they have.
Okay. Okay. What are the post-operative care and how's the follow-up with these patients done?
So now that is a very broad question, because in trans women, if you're actually speaking of trans women who have had a bottom surgery, so that is the most common thing. So trans women with the bottom surgery, the most important thing is that they have to keep that area clean. They have to wash that area daily and keep it clean. Number two is that they should actually use the vaginal dilator every day, 3 times. And they should actually pass the largest dilator and keep it in situ for at least 15 minutes for a year at least. So that is a way of getting a good sized vagina without any constriction happening. Second thing is that that introitus area should always be kept clean, because it's a new world. They have to actually understand that, and they have to keep it clean. And especially the vaginal lining, when it is done with skin, that tends to be actually some sort of debris, skin debris, sebum, etc. could be there. And definitely every third day at least, you have to actually use betadine and saline and nicely flush it with a syringe and keep it clean.
A lot of precautions they have to follow after that.
Yes.
Yeah. How is erogenous tissue preserved in phalloplasty, and does it allow trans men to get erections and engage in fulfilling sexual activity?
Yeah, erogenous sensation. Yeah, erogenous sensation is because of the pudental nerve. Actually, the nerve to the clitoris is taken. See, you have actually 2 nerves for the radial forearm tissue. So one nerve is connected to this pudental nerve, and the other one is connected to the ilioinguinal nerve. So that is giving you the sensation. The other one is giving you the erogenous sensation. So that is how the sensation comes. Because without the sensation coming back, it is inadvisable to actually use silicone stiffening agents for these people. Because in case that is done, there is a high chance that the stiffening agent is going to come out through the skin. Because the pain sensation would not be there, and it would actually come out. So this is how it is preserved. And erogenous sensation is not going to give the person an erection. The erection comes only by using stiffening agents like silicone rods. The rods, the silicone rods are available. It's Indian rods itself. They are the cheapest option, and they are used for actually getting some sort of a stiffening. The people can have erection. We have actually had cis man who had a penectomy for a malignancy, and we had actually reconstructed using radial forearm flap, and we used a stiffening agent also for him, and he has had a child after that. So it is possible to have penetrative sex with this tissue.
Okay. One more question has come up. How to approach a doctor for SRS or how to choose a surgeon?
Actually, the thing is, most of the time you would see that the trans people are a close-knit group, close community, and they would be actually preferring to go to a person who is known in their circles. Currently, like I told you, officially the surgeries have started in India only from 2014. So there are currently very few centers that are doing surgeries for trans people, but the number of trans people is huge. It's like huge numbers that are there. We are estimating that there are around 30,000 trans people in Kerala itself, and it is growing by the day. And there are few centers only doing these things. The most important thing is the government sector currently is not performing surgeries for trans people. They should start doing these procedures, because only then it would become cheap and accessible to everyone.
Again, there's some comments, some input, some costing part of the surgeries.
Yeah. So again, surgeries again depends on the where it is done, how it is done. So the thing is that say for example, top surgeries, when you're actually going to put in the best implant, the implant cost itself is pretty high. It's around 80,000 rupees for a pair, and then we in our center we do it for 1 lakh rupees. This is the same procedure that IMA Kerala chapter has actually sponsored for 10 trans women. The camp for that was held actually a week back at Amrita, and hopefully in the coming weeks, once we get the implant, we would be doing it for these patients. And the bottom surgery, again using the penile inversion, we only take the expenses that we have, and then I think we are charging around 1 lakh rupees for the bottom surgery. It takes a pretty long time. It takes around 8 hours for the surgery, and around 8 to 9 days of hospitalization. So this is what we are charging for the patients. But I know that centers in Delhi charge something like 3.5 lakhs also for the same procedure. For trans men, again, it is slightly more expensive. Probably 1.5 lakhs, because it's a microsurgery procedure, and for phalloplasty. So that is it. And for again for the top surgery for trans men, it would be around 60 to 80,000 rupees for them.
Okay, there is one person who's an MBBS graduate and would like to connect with you and your work. So they're asking how they can do that. So
yeah, you can contact me.
Yeah, so if that is the condition, I think Soumya would be circulating would inform the details. Right, Soumya,
sure.
you would do that, right? Okay, I'll speak to Soumya about it. Yeah, okay. Yeah. So, fine. So, I think there are no more questions. Anju, you want to say something?
Yes, sir. Sir, can I ask one question actually?
Yeah, sure.
Sir, like for a person, I mean, for any trans man or trans woman, whoever it is, how long does it take for them to, physically transform completely to the person that they want to be? How long does it take?
A realistic time frame is 2 years.
And after that, like, how long do they have to keep on taking the supplements and everything to make
lifelong?
Sure?
Supplements they should take lifelong. So that is why they have to actually be under the care of a good endocrinologist. Visit them. They would tell them either 6 months or 1 year yearly visits they have to do. They have to do the testings also, and go for the investigations, proper investigations, and that is it has to be like a connect is there, and they have to be always be careful.
Sir, one more person has asked, I think again Soumya can actually do that. Please share address and contact number for Center for SRS Surgery. I think Soumya will be able to actually give your address and things like that to them. So I don't think there are any more questions now.
Yes. I think Anju, then I think you can wrap it up. It's okay. So first of all, thank you, Dr. Sandeep. Anju, you can wrap it up, I think.
Today, I have to really say that, we had some idea because as doctors, we get to know certain things about transgender surgery and everything in general perspective. But I didn't know as to, how deep everything these plastic surgeons or the doctors that actually help the transgender person to transform into this identity that they want to project outside is such a daunting task, just to keep talking to the patient and then taking them through the journey of the surgery. And then, as you mentioned, the lifelong care that they have to receive from your end also is just something that I think a lot of us would be actually new to this sort of information. Because we thought that, even I thought personally, maybe like 5 to 6 years they'll have to do some follow-ups, maybe just take some medication on follow-up and that's it. But I didn't know that it's a lifelong situation that they have to be very sure before going for the sex reassignment surgical procedures. So, and to get to know that, each and every procedure that they are undergoing are actually done in a very very precise manner. And like every surgeon who's doing it, I think that they are wanting the best, as you rightly told in the beginning, that how they feel when they look in the mirror. And one fine morning they don't want to see that person anymore, and they just want to be themselves, and you guys are actually helping them to reach that. And that is something amazing, I have to say, because whatever difficulties that they are going through, you guys are actually offering a helping hand to them by doing all of these procedures so that they can be their own true self, and which is very important, transgender or not, because you have to be your true self. And you have to project yourself to the society in the way that you want to show them as to how you are. So, sir, I have to say this was such an in-depth presentation, which you actually wrapped up within like maybe 1 hour 15 minutes. I don't know as to how you were able to do that, because you were actually very precise and concise. The only thing, as you said, that the images were not there, like images, but even then you actually made sure that all the points are very precise. So it was not even though it was a little bit of a lengthy talk, we were actually engrossed in your talk. So thank you so much for your time and coming over here and giving us all of your wisdom. So thank you once again, sir.
Thank you very much. Thank you for inviting me,
Yeah, sure, sir.
and good night.